Hello, hello. Welcome everybody to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Lexicon Pharmaceuticals. My name is Rain Bennett. Hello and welcome. If you aren't familiar with me, your host, I'm a filmmaker. I've been working with CCF for almost 10 years, which is crazy, but it's been such a fulfilling journey for me to help tell the stories of NET patients and spread awareness and education about neuroendocrine cancer. CCF's Luncheon with the Expert series is made possible by Lexicon Pharmaceuticals. So first and foremost, we have to say thank you to them. We couldn't do this program without them. And they'd like us to share a disclaimer, which we do every episode. And so I just want to say that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, have not been created or suggested by the sponsors of the Facebook Live program. CCF, the Carcinoid Cancer Foundation, does not endorse nor promote any of the views, opinions, or information provided in this presentation. And audience members, that's you again, should not rely solely on the opinions or information expressed by today's guest, and should seek guidance. Here's the main takeaway: should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that is to say, we're going to give you some guidance hopefully today, but by all means, our guest does not know your specific case. So talk with your own team, build your team that so that you can take the steps you need to go on this journey and hopefully have success. So I'm really excited about today's guest. Today's guest is Dr. Shikha Jain, whom I had the chance to meet in a video series for CCF. I think it was in October last year, which who knows what year it is anymore. It's been 6 months since we've been in the pandemic, and then 2020 is basically a wash. Anyway, Dr. Jain, welcome. How are you doing today?
I am good. It's so good to see your face, and even though it's virtually, it's nice to be connecting again.
Absolutely, absolutely. So for those who aren't familiar with you, and hopefully there's going to be many more that are after today's episode, could you tell us a little bit about your background, where you work, what you do, and what you specialize in the world of neuroendocrine tumors?
Absolutely. So I am a medical oncologist. I'm actually board certified in hematology, oncology, and internal medicine, but I subspecialize in GI oncology. So what that means is I take care of patients who have colon cancer, pancreatic cancer, but my real clinical and research interest is for patients who have neuroendocrine cancers, neuroendocrine tumors, and carcinoid tumors. I currently work at the University of Illinois in Chicago, and I'm an assistant professor of medicine there, as well as the director of communication strategies and the associate director of digital innovation and communication strategies for our cancer center. So I love seeing patients. But I also love doing things like this where I can communicate with patients and kind of help demystify cancer care. So those are two of my big passions.
So it sounds like you have no responsibility at all by that time.
None
You're not
whatsoever.
busy. You're not busy at all. So, and for those, I mentioned earlier that Dr. Jain and I worked on a previous video project for CCF. Well, that video series is now coming out. We have another one coming out tomorrow, actually on Friday, but we've done several of these, I think 4 or 5 out of 9. And you can see those on the videos tab here on the Carcinoid Cancer Foundation Facebook page. You can see Dr. Jain. We've done them we did a ABCs of neuroendocrine tumors, an update from a video that we did 10 years ago, which obviously a lot has happened in the space. We've done carcinoid syndrome and serotonin, PRRT, NETs in children, multidisciplinary teams. We're covering a lot of ground of treatment-based videos. And so thank you for your time with that, Dr. Jain. And for those watching, a lot of value are in those videos. So I definitely recommend you watching them. And if someone doesn't have Facebook, they also live on the YouTube channel of Carcinoid Cancer Foundation. So I see everybody signing in. You know the drill. You're telling us where you're from. Hello from Pennsylvania. Hello from Australia. I love that. We love to hear and see how far these programs reach. This is what our job is. And that's when the last time we had someone from Kenya. Like, I love that these are seen all over the world. It really gives us a good shot at accomplishing our mission, which is to educate people about this disease. So Luncheon with the Experts is a little bit different than our previous Facebook Live shows that we did last year, which we did monthly and that were very topic based. This time we're just taking a deep dive into a member of the NET community. And today is Dr. Jain. And so send in your questions about really anything. She's given us clearance to ask her questions about anything, maybe not everything, but mostly anything. You just heard her bio and what her specialties are. So most of your questions, I'm sure, will fall in that space. But she's here to talk about her journey. From my experience with her, her heart is in this, which honestly, like most people in this community, the NET community, it is like this community is so rich and so strong, and people are doing it with purpose and with mission. And I just love to see that. And Dr. Jain is 100% one of those people. We're lucky to have her fighting this fight with us. We may not be able to get to everybody's question. So if we don't, please know that, number one, this video will live right here on the Facebook page. You can always come back and refer to it. And it also broadcasts starting Monday on the YouTube channel of CCF. And if you have further questions or need a little bit more information, I urge you to contact Carcinoid Cancer Foundation. Either here, you can direct message them on the Facebook page, or just go to their website at carcinoid.org. And finally, we want to say that we know it's challenging to be a NET patient or a person seeking diagnosis, especially in the middle of this pandemic. This has flipped everything upside down. And we here at CCF are here for you whenever, however you need us. And if you'd like to show your support in return for CCF and our work, so we can continue to create programs like this, an easy way that you can do that is to make a small donation. You can text the word experts at 1-914-380-7323. That's experts to 914-380-7323. And every donation helps, especially during this time. So go ahead and send in your questions. Dr. Jain, I want to know a little bit about, just because I know your personal journey, and you just told us where you're working now. When we met, you were working somewhere else. So you just recently started at University of Illinois, correct? And
yeah, I've only been there for about a month. I actually did my residency there many, many years ago. So it's nice to be back as faculty now.
So it's coming home in a sense.
Exactly.
So, and what are the things that you're excited about? Are there new roles or responsibilities that you didn't have previously that you get to dive into here? What is the future hold for you at this new institution?
So the biggest reason that I came back to University of Illinois after this many years is the patient population we treat there is so diverse, and they gave me the opportunity to continue my first passion, which is clinical care, but then also really addressing the disparities that exist in healthcare that we're seeing kind of amplified during this pandemic. We take care of a lot of patients who come from more underserved areas, and one of my skill sets is this communication with patients and being able to reach patients at every level. And so I'm trying to implement strategies at the University of Illinois that will help us reach patients that are often have challenges getting medical care, particularly oncologic care, but eventually, hopefully, some of the studies that I'm doing and research I'm doing will expand so that we make the patient experience better for all patients. So I'm using things like Facebook Lives and digital innovations and things to try and reach patients in their homes and find ways to really help care be more accessible to everybody.
This is really something that I'm passionate about and is of importance to me. I come from a rural, poor, area in North Carolina, and people seeking, cancer rates are very high, to put it simply, and the care people are able to get is sometimes a struggle for people. Or what types of people do you think suffer from this disparity the most? Is it just an economic thing? Is it a geographic thing? Like, who are the people you're seeking to serve with these new strategies you're trying to implement?
So I think you bring up a really good point, which is different parts of the country actually have very different barriers and challenges. So like where you're from in the more rural space, the problem is there may not be an expert or a specialist nearby, or it may be really difficult for you to get to a clinic or a hospital where they have resources. So the increase of telemedicine visits has really helped patients in those rural areas where they can access a physician over the phone or over the computer. So that's been a really big thing, I think, in the last 6 months with the pandemic. That has been huge, especially for those patients in more rural areas. Now, a bigger challenge or another challenge is those patients who just don't have access to care because either they mistrust the medical system system, our African-American populations, especially, you know, after Tuskegee and a lot of things that have happened over the last several decades. There's been so much uprising that's been happening with the public health crises, with the protests, and people just mistrust the system. And so a lot of it is educating and really getting people to know that we are on their side and the physicians are there to help them. And really, by opening communication lines and talking to patients where they are, talking to them at the level that they're at, and explaining to them that we're a team, I think is really important in addressing some of these disparities. And then there's always, you know, health insurance and just access to care. So my hope is that the things that I am starting to implement and study at the University of Illinois will be able to make it so that, one, patients trust healthcare and trust the healthcare systems. Two, the patients who can't access the healthcare because they can't get to the appointments will have access through things like video visits. And then really just trying to fix these systemic inequities that exist in healthcare at kind of a systemic level. So that's what I'm hoping. I mean, you know me, I have very big plans that I set my sights very high to make big changes. So I'm hoping that that's some of the stuff I'm able to do through this new role to help our patients in Illinois and then eventually across the nation by implementing some of these strategies at other institutions as well.
Man. Well, you have my full support. I don't know what I can do, but I'm really proud of you for doing that and fully support it. And honestly, I just got pretty emotional when you were going through that because, you know, I lost my dad to cancer. It was lung cancer, but and even though my dad's not an African American, when you come from a poor area, like a lot of the same issues you're dealing with, a lot of African Americans are also in low economic situations, and so in Eastern North Carolina, it's a lot of the same culture and mentality. My dad was the same way, like strong, silent type, didn't trust going to a doctor. And what happened? He went when it was far too late. And so, you know, personally, that just touches me. These are the people that I fight for. So I love that these are the people that you fight for as well. And I 100% agree that distrust, that mistrust is there. And it also makes me happy and fulfilled because our job at CCF is to educate people. The more we can educate the general public and the healthcare providers, the more chance that we have. But I think that link is so crucial. And so, you know, personally, I want to thank you for doing that work. I appreciate it, and I know a lot of people do as well.
Of course.
I was also thinking like this. This is a tragedy that we're going through with the pandemic, and not to just be this eternal optimist that tries to see the silver lining, but there are some changes are going to be made that sustain that we should have been doing better all along, right? And this thing about telehealth, I'm glad that you went there as well, because I've seen this happening. I don't want to digress too much, but there's a client that I work with that does housing counseling. And they were really struggling to serve their people because it was a physical thing, and people may not have access to printers to fill out the forms, or couldn't even get to the office. And then the pandemic hits, and they really, you know, can't do any of these physical in-person services. So they had to creatively pivot, and they created this online form that's able to do it, and they're able to serve so many more people simultaneously while these moratoriums on evictions and foreclosures are ending. So there's going to be this housing crisis. So that presented them with an opportunity to pivot in a creative way that actually helps them serve people, you know, more and deeper. So you know, there are things that I think will be good from this, even though it's a tragedy that it's happening. So I love all the social work. We're getting questions in, so I think I could nerd out about that for the entire hour. But for the sake of our amazing audience, we're going to go ahead and get into some questions.
Sure.
But congrats on the new on coming home and the new position. And you know, I wish you well in all the endeavors that you're working on. So, okay, we're going to get into this, and I'll say to everybody listening, if you're just joining us, we're here with Dr. Shikha Jain from the University of Illinois. Send in your questions. We can't really get to very case-specific questions. I've already talked to Dr. Jain, and she's going to try to give you the best generic advice that she can. But just know that she's not your doctor. She doesn't know your case. So if it's super nuanced or detailed about your case, we may not be able to give you a direct, specific question. We may ask you to clarify or rephrase your question in a general way. And I see the community talking to each other in the comments, which we always love to see. So first of all, we have a message from, or a question rather, from Renee, Dr. Jain, who says, I get lumps after my octreotide injection every time I use a wheat pack before and I ice after. Any tips? Does that make sense? I'm unfamiliar with what a wheat pack is.
So I have so many patients who've given me a variety of different home remedies for what they use to help with those lumps, because they can be painful, those shots. I mean, no one likes shots to begin with. Octreotide shots can definitely be painful. I have found some people really like ice packs. Some people really like warm packs. So that's something that I think it's a personal preference, but I've seen anecdotally, some of my patients have liked one versus the other. Some of my patients who really suffer, like have trouble taking the shots, I recommend they take some Tylenol just before they come in for their visit. It helps with some of that pain that they get. But I think that's, if that works for you, I think that is great, but it really is a personal thing. I have a lot of my patients do trial and error, where one time they'll try an ice pack and the next time they'll come in and say, Dr. Jain, that didn't work at all. And I'll say, okay, well, try a heat pack this time. But the patients who really struggle, I usually tell them to take a little bit of Tylenol before they come in to get their shot. Got it.
Thank you. Hopefully that helps, Renee. We have a question from Ajay, maybe Ajay. Dr. Shikha Jain, any relation between PNETs and chronic myeloid leukemia?
So Ajay, it's a good question. I think you're asking if you develop a PNET, if you have a risk for developing leukemia, is how I'm interpreting the question, or if they're related in the sense that does one put you at higher risk for developing the other? There isn't any evidence that I know of that shows that the two are linked. There are some metabolic syndromes where if you have certain types of neuroendocrine tumors that you're higher risk for developing other endocrine cancers, but I don't believe that leukemia and PNET is specifically linked in the sense that one doesn't put you at risk for the other.
Got it. Okay. Next question that our numbers are rising too. That's always nice to see. And listen, for those at home, if Dr. Jain does a great job, an easy way to visually let her know, I always like to tell you all, is to send one of those little thumbs ups or those little heart emojis at the bottom. Let us know that we're doing our job. It's always nice to see. I'm using Captem. Okay, so Alan says, we're still talking about PNETs here. What is your opinion on using Captem, and let's establish what that is, in the treatment of PNETs with metastases?
So Captem, for those who don't know, it's two medications, capecitabine and temozolomide, that are utilized in patients who have PNETs. So my opinion is it depends on the specific case. So there are some patients who I think are great candidates for receiving Captem. You have to, when you're looking at a patient, so when I look at patients in general, I look at a lot of things. So the first thing you want to look at is the tumor itself. So when you look at the tumor, you look to see how aggressive it is. We often grade these types of tumors. So a higher grade means it's more aggressive. There are some PNETs that are not very aggressive. So when it comes to neuroendocrine tumors, and PNETs is what we're talking about now, there are different stages as well. So if you have a PNET that seems pretty benign in the sense that it doesn't seem like it's very aggressive, doesn't seem like it's going to grow very rapidly, then something like a surgical intervention may be beneficial. In somebody who has a metastatic PNET, the question then occurs as to how aggressive it is. And then when you assess how aggressive it is, that's when you decide what the correct treatment option would be. The next thing you look at is the patient themselves. So when I talk about personalized cancer care, that to me means looking at the patient, seeing what their home situation is, seeing how active they are. So there's something as oncologists we utilize called performance status. What a performance status is it tells us how active you are. We might ask you your activities of daily living. So I might ask a patient, tell me, what time do you get up in the morning and what do you do throughout the whole day? We're trying to figure out how active you are, meaning, are you in bed for more than half of the day? Are you bedbound because you have another medical problem? Are you really fatigued? Are you really sick? Is it the PNET that's causing these problems, or is it something else? People who have a poor performance status or people who aren't very active, people who are bedbound, oftentimes may not benefit from some of the more aggressive therapies that we offer, because it might be more dangerous to give it to them than it is to not give them anything, or to give them something less aggressive. So when we talk about things like CAPTEM and other chemotherapy agents and other agents, we really want to look at a full picture, both at the tumor makeup and also, well, at the tumor makeup, at the amount of spread or where the cancer is or where the PNET is, and then also the overall performance status of the patient to see what they could tolerate.
I think that's a great point. I mean, it's the same thing with, not to bring up my dad again, but when he was going through chemotherapy, it's like you're trying to eat as well as you can and build up that immune system, build up that strength. But what you're saying is it also applies to physically how you're moving around. And basically, it makes you stronger to kind of fight this. So my question is to follow up with that, because I think that's a totally good point. I come from a fitness background, so I know the value in that. A lot of people don't have the energy, don't have the motivation to, and tend to see it as this like binary thing where either I'm laying in the bed or I'm running a marathon, right? And that there's not this whole world in between, right? So my question is, for those that are might be dealing with that, like, I hear you, Dr. Jain, I need to be more active, but it's tough. What are some simple ways that they can ease into this? Because I don't think what you're saying is you need to be out there and doing CrossFit competitions and like running marathons. What does it really mean to be more active?
So that's a great question. Before I answer it, I want to make one point as well.
Please.
So I had a video visit with a patient yesterday who couldn't come into the office because he is bedbound, but he is not bedbound because of his cancer. He is bedbound, and he has been for years because of a completely unrelated issue. Now, other than the fact that he is bedbound because his legs don't work, he is otherwise in good physical health, meaning his upper body strength is fine. He's awake for most of the day. So he is somebody who, despite the fact that he is bedbound, he can still get certain therapies because him being bedbound doesn't actually affect his activities of daily living. And he is healthy other than the fact that he is in a bed. So
even bedbound, you can still choose to, or still be active and have a better, what was the
performance status.
Performance, yeah. So that's I'm so glad that you mentioned that. Thank you.
But going back to your original question, so I actually make that joke with my patients all the time where I tell them, I'm not expecting you to run a marathon. Right. I have some patients who are very physically active. Like I have one patient who actually does run marathons and used to run home from his treatment. Like he'd come get treatment and then go run back to his house, which was 10 miles away. But I have other patients who are they feel crummy. They don't want to move around. It's much easier to come home and sit on the couch or sit in bed. So what I tell those patients is, I'm not expecting you to go out for a run or go for a bike ride. What I want you to be able to do is just go out for a walk. The pandemic has made it more difficult because obviously we also are trying to be careful, social distance, wear a mask. So there's been an added challenge of that during this pandemic. So what I've been telling my patients is a couple of things. Number one, we've found that patients who exercise even a minimal amount, and again, when I say exercise, I don't mean go for a 5-mile run. I mean, go out for like a 15-minute walk, not a brisk walk, just a walk, just to make sure you're being mobile and you're getting around. Those patients tend to fare better when they're getting therapies, and they tend to have better outcomes. There are lots of studies that have come out showing that type of thing. So when you're feeling crummy, when you're feeling tired and you don't want to move around and you don't want to exercise, what I recommend is grab, someone who lives in your house, your partner, your friend, your roommate, whoever you live with, and just say, hey, would you mind coming with me for like a 10-minute walk? Put your mask on, go outside for a 10-minute slow walk, use it to socialize. If you're like me, I like to exercise while watching TV. I haven't been able to go to the gym for a really long time because of this pandemic. So what I've been doing is I'll put something on my computer and I'll do 10 minutes of physical activity in front of my computer. So there's a lot of ways to be active that don't necessarily mean you have to be doing CrossFit or going for a run. It's just getting up and moving. And a lot of it is physical because cancer sucks and it can really suck that life and that energy out of you. You can lose your motivation. Your body in general just doesn't feel good. You're nauseous. You are tired. You just don't want to do anything. So what I try to encourage my patients to do is to have time in your schedule every day where you just say, okay, I'm a morning person. So at 10 a.m. every day, that is my 15 minutes to go exercise. And my patients who actually implement this and put it in their calendar and actually abide by it, one day it might be you go for a 15-minute walk. One day it might be you do yoga. One day it might be that you're just sitting at home and you turn on a exercise video, like a Pilates video or something. But I think that it's really important to have that time scheduled. So mentally, this is my time for exercise, and it keeps you motivated to do those types of things. And at the end of the day, it will help you. And I call my couch the black hole, because when I sit on my couch, I won't get off of it. It is my black hole. And my husband and I joke about it all the time. If we ever want to exercise, if we're coming home from work, we can't sit down on the couch, because if we do, it's not going to happen.
Absolutely.
So by having it scheduled into your day, and just like I said, put 15 minutes aside and find a way to do something that's physical, that will help you immensely as you're going through treatment. And it will be a struggle initially, but eventually it'll just become a part of your routine.
Totally +1 to that. And just to piggyback on top of that, it comes down to habits. To your point about don't sit on the couch, because that's going to kick in a psychological habit, that you have created over time for you to, okay, now it's time to Netflix. Now it's time to have that glass of wine. Conversely, and there's a great book by James Clear called Atomic Habits. Amazing book about how to reset these habits. And there's been studies that show if you do something just as small as putting your walking shoes, taking them out and the shorts that you're going to walk in and just putting them by the door or by the foot of your bed, that one little pre-action makes the action happen. Whereas if you just rely on your willpower and discipline, it'll last for maybe a little while, but then you'll be back on that couch and in the black hole.
Exactly. It's so hard to do. I will tell you, the last 6 months have been really hard for me as well. I mean, partially because just going outside, everybody's nervous, and sometimes it's hard to exercise in a mask, but I've been able to run in my mask. But I definitely spent a lot of time sitting on the couch the last couple of months.
I know. And the food is all over the house, and I know. I feel your pain. All right, let's get to some more questions. First of all, hello to Claudia from Germany. Hello back. Hello to Prem from India. Reaching all over the world. Love it. All right, carcinoid syndrome. We got a question from Effie about carcinoid syndrome, and you and I have talked about this. Can intermittent low-grade fevers be a part of carcinoid syndrome? Is that a symptom?
So first, I think the question is going to be defining what an intermittent low-grade fever is. So Thanks for your question, Claudia. I think the diagnosis of a fever is a temperature of 100.4 or higher over an hour-long period, or over 101 once. So that's how, as oncologists, we define a fever, and that's in Fahrenheit. So 100.4, and then you recheck it 30 minutes to an hour later, it's still above 100.4, or if you get a temperature of over 101. So carcinoid syndrome often is accompanied by flushing or feeling very hot. So oftentimes when you're going through those feelings of flushing or hot, your temperature that is recorded on the thermometer may indeed be slightly increased. Now, if you're having an actual fever, it's less likely that's coming from carcinoid syndrome. But if you're having something where your temperature is a little bit higher than your normal baseline, then that could be something that would indicate that you're having symptoms from your carcinoid syndrome. Now, that being said, if you are somebody who does not have a diagnosis of carcinoid syndrome, and you are getting temperature fluctuations where you're getting these what people call low-grade temps, where your temperature is a little bit higher than your baseline, that does not mean that you are having symptoms of carcinoid syndrome unless you've been diagnosed with it previously. So don't call your doctor and say, I'm having these fluctuations in my temperature, I have carcinoid. I think I have carcinoid syndrome. It's more if you have a known diagnosis and you feel those feelings of flushing and feeling like warm, it is possible your temperature may go up slightly when recorded on the thermometer.
Got it. Awesome. Hopefully that helps, Effie. Hello, Wendy, top fan. If you have a story, I have one. Would love to hear that later, Wendy. Greetings from Puerto Rico. Hola, Mayra. ¿Cómo estás? Okay. I like this question. I may have asked you this when we were doing your interview. I always like to hear the backstory. Linda says, how did you get interested in the neuroendocrine side of cancer specifically?
It's a great question. Thanks for asking me that, Linda. I actually got interested about 5 years ago because I had two patients who I just adored. And they were very different patients though. One of them had a very chronic neuroendocrine tumor. She'd been treated with octreotide shots for, I think she was on year 12 or 13 when I inherited her as a patient. She was the nicest woman. I saw her every month for her shot, and we got to talking, and she basically explained how when she was diagnosed, she was so miserable. And then when she started getting these shots, her entire life changed. She said she went from before she was diagnosed, before she was having any symptoms, she was very active. She was out doing things. Then she got diagnosed. She was very depressed. No one could figure out what was wrong with her. She was staying home all the time. She wasn't doing what she enjoyed. Then when she was diagnosed, she said it was like she went back to being who she was before she started developing symptoms. And that was, 12 years ago when I met her. And for 12 years, she said, I feel like you guys didn't just save my life. You gave me my life back, because I was existing, but I wasn't living when I was having these symptoms. And when I was diagnosed, I all of a sudden realized that I had become a completely different person, and you gave me my life back in more ways than one. So when I met her, I thought, wow, what a powerful story, and what an amazing way to think about how you could treat somebody like this. My second patient who, she was kind of the one who had a much more aggressive course. She was on octreotide shots for years, and then she progressed, and she ended up needing PRRT therapy. And so I initiated her on the PRRT therapy. For those of you who don't know, that stands for peptide receptor radionuclide therapy, which is not available everywhere, but it's available at some institutions. And so when I initiated that therapy with her, after we treated her, we saw things shrink pretty significantly. And she, again, her situation was different in that we needed to do a more aggressive treatment plan. But she also felt that after, going through the treatments were a little bit rough for her. She was having some side effects, but afterwards she said she felt like a new person. And so those two patients really spoke to me, and I started reading more and more about neuroendocrine tumors and neuroendocrine cancers when I was taking care of them, because the first woman, she was one of the first patients that I had treated as an attending physician with that disorder. And so the more I read, the more fascinated I was by the science. And then I started getting more and more patients, and I fell in love with the patients I was taking care of. I mean, I love all my patients. I think my patients are wonderful people, and I love getting to know them. But just hearing these stories, it had such a profound impact on me that I decided that I wanted to really start focusing more on treating these types of patients and become an expert in this particular aspect of GI oncology.
Everybody, can I just take a moment to commend Dr. Jain on her storytelling abilities? For those that know me and my journey, I'm a storytelling nerd. I'm a filmmaker and writer, but specifically I help people tell better stories to connect with their audiences and raise awareness for their causes. And you just did an excellent job, Dr. Jain, of establishing, the balance beforehand, the problem that comes, the conflict that shakes it all up, and then what change has to happen to restore balance to the life, especially in the story of your first patient. So I just want to say that was well done. And for those at home, I don't know about you, but as soon as you started telling that, I lean in, and that's what happens when you share stories. We've talked about this on the show before, and those that come back every week know that sharing stories is such a powerful way to connect and to help people see their way through the darkness. So I just want to take a moment and say that was expert level storytelling.
Thank you.
Yeah, absolutely. You know what you're doing. So Frank says, ask a question about, he heard about the chemical drug Captem and asked about it. So Frank, and for anyone else, we have touched on that already. And so I'll just say that, if you need to go back and watch this video, it'll be here, evergreen content on the CCF Facebook page. And we also publish it to YouTube for those who don't have Facebook. So anyone you think would benefit from this, send them the link and they can refer back to it if you have questions that we aren't able to get to it able to get to. And then Alan actually follows that up and says, great response on the Captain question. And as far as exercise, get a border collie puppy. Nice too. Exercise is an understatement. So, yeah, we can see that we're definitely getting +1s to that. So we're just a little bit over halfway through, everybody. Welcome if you have joined us late to Luncheon with the Experts with today's guest, Dr. Shikha Jain. We're having a great old time. Get your questions in while we have her for about 25 more minutes. Okay, so Monica says, I've been told neuroendocrine cancer has a quote unquote better prognosis than most since it's slow growing, but is there a difference in where the primary is, such as pancreas versus gastric with life prognosis?
So that's an excellent question. Thank you for asking that, Monica. So the interesting thing about neuroendocrine tumors is they can show up in a variety of spaces. So even though I'm a GI cancer specialist and I see them in the intestines and in the pancreas, they can also show up in the lungs and in other areas of the body. Now, different areas of the body have different types of neuroendocrine tumors. But the interesting thing is a lot of neuroendocrine tumors, despite where they are, can be very, very slow growing. So many neuroendocrine tumors are indeed very slow growing and have a better prognosis than many other malignancies or many other cancers. Now, the challenge is there is this other section of neuroendocrine tumors that are more aggressive, and some of them behave much more like aggressive cancers. So, for example, there's some neuroendocrine tumors that you see that behave like certain types of aggressive lung cancers. So those patients are the ones who often cannot get things like octreotide therapy or PRRT, as we mentioned. Those patients often go straight to chemotherapy that we would use similarly for very aggressive lung cancers. So the location does matter. There are different locations that have different prognoses and have different ways that they respond. But when you're looking at the tumor itself, the best way to really determine how aggressive the neuroendocrine tumor is by looking at the tissue. So as an oncologist, we always, oncologists don't joke very often, but when we do joke, we say the tissue is the issue, which basically means that when you take the tissue, that's when you know the issue. So to get a really good understanding of how aggressive the neuroendocrine cancer or neuroendocrine tumor is, we need a biopsy. Then we look at the biopsy, we see how well differentiated it is, which means how much it looks like normal cells versus how much it looks like more aggressive, undifferentiated cells. Or also we look to see if it has hormone receptors on it. We look to see if there's different ways we can target it. So looking at the actual biopsy in the tissue is really one of the best ways to tell how aggressive the actual neuroendocrine tumor is. But the majority of them tend to be pretty well treated and pretty slow growing.
Awesome. Thank you for that. And hopefully that helps, Monica. I have a question from Wendy, who is a top fan. What's up, Wendy? Good to see you again. Is there any help out here for zebras on Social Security disability insurance? Not on treatment, already whippled, liver resections and hysterectomy. I can't find any resources. Any guidance or help for Wendy there?
So the question for Wendy is on social, explain it again, the Social Security.
Yeah, she says, are there any help out there for zebras patients on SSDI?
On SSDI, okay. So, it's always zebras. So for those who don't know, go ahead.
Did I get that wrong? What is SSDI?
No, you're right. You're right.
Okay.
What I was saying is, when I was going to explain what a zebra is. So zebras in general in medicine, when the way that kind of phrase has come about is
yes.
when you're training, people teach you that when you're looking at a diagnosis, and it's like when you hear hoofbeats, you think of horses, not zebras. So when you diagnose somebody, you want to think about the more common things. So zebras, the way we describe zebras, are more rare types of tumors, more rare types of diagnoses and disorders. So the best resources I can recommend if you are somebody who has a very rare tumor, a very like a zebra type tumor where it's something that maybe there's like 50 people who have it in the entire country or in the world, which those types of tumors do exist. I strongly recommend going to an academic institution who has a very large department or a large number of physicians who are looking at that type of disorder. The best way to find those types of resources and to find those types of physicians is you can look at papers that have been published. I can guarantee there'll be case reports or there'll be small studies looking at that particular type of tumor and see the people who've written the study, where do they practice? And then see if you can get more information about if they have some hospitals actually have clinics dedicated to these types of very rare disorders. So if you find the physician who wrote the paper, you may actually find a clinic that focuses on your type of cancer, your type of zebra diagnosis. So that I would say that's the best way, especially for people who aren't limited by location. I've had patients who've flown to come see me in Illinois. There are patients, people fly to Sloan Kettering and MD Anderson and institutions across the country. So I would say the best way to find information would be to look up medical articles that have been published on your particular disorder, and then see if you can find where that physician is practicing, call that place and ask them, do you by any chance have a clinic or have somebody who could see me specializing in this particular disorder? And that is the best way to find somebody who would probably have the most information and the best way to really diagnose and treat you.
Absolutely. All right, Wendy, hopefully that helps in your journey. So I have an interesting question back to carcinoid syndrome from Adriana, which is basically the opposite of our previous question. She asked, can chills be a part of carcinoid syndrome? We talked about fever.
Also a great question. And it can. So people manifest carcinoid syndrome in different ways. Some people develop severe diarrhea. Some people have no diarrhea. Some people's faces turn very red. Some people's faces don't turn red. Most people, when they have carcinoid syndrome, it's more common for you to feel very hot and feel very warm and get that flushing sensation. So I think chills are less common. But some people, when they feel flushed, they also get chills. So I think it really is person dependent. And especially the other thing, this is very interesting, and I did not realize this until I became a physician. People describe things very differently. Like one person will tell me that they're feeling chills, but then I will delve in a little bit deeper and say, explain to me what you mean by chills. And actually what they're feeling is flushing, but they're describing it as chills. So I think it's important to remember with carcinoid syndrome, the more stereotypical presentation is this flushing, this face getting warm, diarrhea, heart racing. Those are some very common symptoms with carcinoid syndrome. But if you have a diagnosis of carcinoid syndrome and you're having other symptoms that you think might be attributable to it, sometimes I recommend patients keep a log. It might be associated with a certain food that you eat. So if you develop a symptom, think, what have I been doing for the last 10 minutes? If you develop a symptom, write the time. So maybe it happens more often when you first wake up in the morning or in the evening. And then when you go to your doctor's visit, you can show them this log that you have of, well, I developed these symptoms at this time. This is what I did immediately before, or this is the food I ate immediately before, or this is, the clothing I was wearing. So anything that you think might be relatable, and you might actually start seeing patterns yourself where, every time I eat walnuts, I develop severe flushing. So that answers some of the chill question, and then also kind of how to figure out if the symptoms you're having are related to your diagnosis.
I think the log is such a great piece of advice, like totally. And it takes a little bit of time to figure that out. But if you don't measure the data, you don't really stand a chance. You're just like grasping at straws, right? So that's such great advice because often it can be attributed to something else. And you brought up maybe something that you ate. I will say, Adriana, that we also have videos on nutrition. We've had a Facebook Live on nutrition as well. So we do have some sources or resources here at CCF that may be able to help with any nutrition questions as well. I want to go back to CAPTEM because we've had a lot of comments about it since then. And a couple are kind of in the same vein. So this question from Donna says, do you consider CAPTEM to be an aggressive treatment program? And then someone else, Alan, I believe, had mentioned that it was worth mentioning its toxicity. So can we talk about maybe the cons or those questions? Like, is it something we should be concerned about, the toxicity? Do you consider it an aggressive treatment program?
So I'm going to be political in my first answer about whether it's aggressive or not. So I think it really depends on what you consider aggressive. So I treat all different types of cancers. So there are some treatments I give that are very, very toxic and are very, very aggressive. I think CAPTEM is kind of in the NET community, in the neuroendocrine community. I think it's more aggressive than things like octreotide for sure, because it's actual systemic chemotherapy. But on the same token, I would not call it an aggressive therapy in that there are much more aggressive chemotherapies that exist,
Okay.
even for patients with neuroendocrine tumors. So people who have those high grade neuroendocrine cancers that behave like the small cell lung cancer, we give them more aggressive chemotherapy, more aggressive regimens in CAPTEM. So is what I'll say about aggressive. It's more aggressive than octreotide, but not like at the highest level of aggressiveness you could, if you're looking at a scale of cancer care overall.
Got it.
So talking about toxicities. So the toxicities that are most common with CAPTEM, people complain of diarrhea. That's something that I hear a lot of. People sometimes develop this hand-foot syndrome where they'll get like rashes or numbness and tingling in their hands and feet. So I've seen that sometimes. We can sometimes see their blood counts kind of fluctuate. So you might develop some lower blood counts, your red blood cells, your white blood cells may go down a little bit. Those are, I would say, the diarrhea and the hand foot are the more common side effects that I see.
I'm sorry, the hand foot thing kind of threw me off. Is that I thought that because my daughter had that like in preschool when she was very young, or daycare. It's not preschool yet. I thought that was just something that children dealt with. So that's something that can manifest here as well.
So I should clarify, it's not hand-foot syndrome like what you get as a kid, like an infectious process. It's more just like rashes. And sometimes numbness and tingling, but it affects the hands and the feet. So it's not like the hand-foot that you can transmit from person to person. It's side effects that affect the hands and the feet.
Okay, that threw me off, because when that happened to me, that was a new thing to me. You know, my wife was like, "Bellamy's got hand, foot, and mouth disease." I'm like, "What is that?" I mean, I could put context clues together and figure out part of it.
If anyone is watching this Facebook Live and you rewind it and you only watch that part, it's not hand, foot, mouth syndrome.
Okay, from Claire, we have, what are your thoughts about taking metformin and NETs? We hear a lot about metformin. She says there are a lot of studies with benefits. Any thoughts to weigh in?
So I've definitely had some patients who've taken metformin and have felt some benefits, especially symptomatically. So I believe, again, that's a very personalized decision between you and your oncologist. I think there are some people who would benefit from it, and I think it really needs to be a decision that's made talking to your care team. But I do think that there are some situations that it could be beneficial, but again, it's very case specific, and it would be a discussion that you need to have with your physician and your care team. But yes, I do think that the data is interesting and intriguing, and in some cases it does seem to be effective.
Got it. Lisa Yen says, beautiful story. I'm assuming she's referring to your patients. Hey, Lisa, remind me, she's going to be a guest on this show. And so remind me, I need to get a headshot from you. I'll talk to you soon. Linda says, thank you so much for your answer on your neuroendocrine interest. Everyone will certainly benefit from your care. Love these luncheons, and we love you being here, Linda. Thank you so much. For those that have joined us late, we have just a little less than 15 minutes here with Dr. Shikha Jain. She has been awesome. I've had a blast today. I hope you all have too. And I learned a few things, as we just pointed out. And so hopefully you have too. And again, I'll reiterate, if you have follow-up questions, or if we weren't able to get to your question, because it's a double-edged sword. We love that we get a lot of interest and a lot of questions, but we unfortunately only have an hour and we can't get to all of them. So if we didn't, or you have follow-up questions, just reach out to Carcinoid Cancer Foundation, either at their website, carcinoid.org, or here on the Facebook page. You can send them a private message. So Effie, which we've heard from already, says, I believe this is the same Effie. What are your thoughts on microscopic disease? Not visible in scans, but symptoms continue or symptoms increase.
So microscopic disease is a challenge because, as you said, we know it's there because you're having symptoms. And some of my patients have actually complained to me where they say, I feel crazy because they're looking at the scans and we're not seeing anything, but I'm still having these symptoms. And I hope you believe me that I'm actually having these symptoms. So it can be very frustrating for patients when your doctor is sitting and saying, well, there's nothing on your scans, I'm not seeing anything, but you're still having the symptoms, and you know your body and you know that something is wrong. So I think that it's a real problem. And in cases like that, so patients who are having symptoms, who are having microscopic disease, I mean, most of them I will continue on hormone therapy, especially if it's helping their symptoms. I think that's really, really important. And that comes with having an oncologist that you trust and having a team that you trust. You need to be able to have these open discussions so that even though the objective data that we're looking at may not show a tumor or a mass, there is the possibility of micrometastatic disease. There is a possibility of having microscopic disease. And you need to really kind of finesse that out when you're having your visit with your doctor and figure out, are the symptoms that you're having consistent with the fact that you may still have some microscopic disease? Are you getting benefit from these shots or whatever your treatment is? Should you continue it even though you're not seeing it on imaging? So I think that it is a real problem a lot of patients face, and it's something that you just need to make sure you have an open conversation with your physician. I tell my patients all the time, I don't go home with you. I don't live with you. I don't know what your life is like. I don't know what your job is like. I only see you for, 15 to 60 minutes in the clinic. And then, whatever times we talk on the phone or you send me my chart messages. So I can only help you as much as you share with me. So if you're not telling me things, if you're not telling me you're having these symptoms, and then you go home and you're miserable until you see me again in a month or in 3 months, then I'm not doing you a service as your physician because I'm not helping you. And you're not doing me a service because you're not giving me the tools or the information I need to give you the tools to help yourself. So I think, one thing that I really advocate for, I know, especially, with doctors having minimal time, we're always rushed and we're being told you need to see patients, this many patients in this amount of time, and you only have this amount of time with your doctor. I really recommend to my patients, I mentioned lists earlier. I think it's really important to come into your visits as organized as you can. Come in with a list of the symptoms you've been having. If you have a log, bring that in and be honest with your doctor. We're not going to judge you. We're not here to make fun of you. We're not going to, attack you. Our job is, we're here to help you. We went through a lot of training to get to this point, and all we want to do is make your life better. We want you to go home and be able to live your best life. Like, that is our job and that is our goal. And we do that by you sharing with us the symptoms that you're having. So that's a long answer to micrometastatic disease and systemic therapy.
No, but it's perfect. And you're an agent of them, right? An agent acts on behalf of the principal. So yeah, be honest. The three people, with your doctor, your lawyer, and your therapist, like, those are people you should never lie to, right? And it's tough to be honest and vulnerable, but these people are acting on your behalf, right? So definitely a plus 1,000 to that. Thank you for saying that. Listen, everybody, we've got a little bit less than 10 minutes. I wanted to say something that an idea that I just had that I think would help me do a better job in helping you. I have a question from Craig that I'm going to ask. And one of the things that made it stand out was I've seen a couple of people like that question. So that tells me that there is further interest in that. And it's not just specific to Craig's experience or, Craig's specific case. So let's do that as you, and still send in your questions. But as we do these, it's really, that's a, I scroll through the comments, and that's a really helpful way for me to see that there is demand for that question. Because like I said earlier, we can't get to all the questions. So that's just an easy way. If you see somebody's question, you're like, ooh, I want to know that answer too. Just give it a like or a love, or now they have the care emoji. Any of those will do. And then I can see that like multiple people have liked that. So just a little thought I had that I think would help us kind of streamline some of those more important questions that a lot of people are asking. Craig says, in the next 10 years, Dr. Jain, where do you see major breakthroughs with treating NETs? And specifically, he's curious about immunotherapy.
I love that question because my other passion is immunotherapy. So
nice. Good job, Craig.
Excellent question. So I love immunotherapy for a variety of reasons. I love it because it has completely revolutionized the way we treat many, many, many cancers. Everything from kidney cancer to melanoma to lung cancer to colon cancer. There are a lot of immunotherapy agents out there that are pretty impressive in the way they work. I think that the fact we've learned so much about the human body and the immune system and how the tumor microenvironment and really the body's microenvironment is, we've learned so much in the last several decades that we've been able to utilize that to create these immunotherapies that activate your immune system to really fight off cancer, which I am fascinated in. And I lectures on this actually, and it's interesting that a little history lesson for you. 1950s is when they first, when somebody really started to put into words, a scientist put into words this concept of the body's immune system being able to fight cancers. And since then, we now have a variety of immunotherapies that do just that. So I love immunotherapy with the caveat that it does not work for every type of cancer. So right now, what we're learning with immunotherapies and what we're trying to discover is how we can predict which patients really benefit from immunotherapy. And what we're finding is by doing this, the buzzword these days is next generation sequencing and precision medicine and precision oncology.
Right.
By utilizing those types of effective ways to assess the tumor and look at the markers on the tumor, look at how the tumor is made up, we're able to really see which tumors might respond to some of these immunotherapies and which patients might get the most benefit. So my hope is over the next decade, we find ways to incorporate immunotherapies into the more aggressive types of NETs. Now, that being said, the less aggressive NETs, so we've talked about, some of these neuroendocrine tumors, people live for decades and have completely normal lives and live until their 70s, 80s, 90s, just getting these shots. And yes, I know it's a pain, literally and figuratively, to go get a shot with your doctor every month, but we've been able to utilize that type of therapy for the less aggressive neuroendocrine tumors to keep people alive to almost their normal lifespan. So I'm hoping that immunotherapy will really be able to we'll be able to look at patients who have that more aggressive type of neuroendocrine tumor that we haven't been able to really figure out how to prolong their life to the level and the extent that we've been able to with the less aggressive NETs. I am hopeful that we will be able to use immunotherapy in those patients as we learn more about the tumor microenvironment and learn more about how those tumors are composed. So I am cautiously optimistic that when we do this Facebook Live, I'm sure there'll be like a hologram of me standing up in front of you at that point in 10 years. When we do it then, I'll be able to tell you that we have immunotherapies now that are approved for patients with the more aggressive neuroendocrine tumors.
I love that. And I'm going to hold you to that. We're doing this again in 10 years. I'll see you in 2030. Hopefully it'll be a better year than 2020.
Hopefully.
I think we got time for maybe one or two more questions, probably just one. Linda says, I do like this question. Linda says, what should people do who are in a wait and watch status? If a tiny net is found, this was by chance, and removed, and additional tests don't show evidence of other tumors, what further testing should be done at what intervals? In her case, the tumor was very tiny in the stomach, and she read so much information about treatment for full-on NET patients. But what about those who had this, NET removed by chance?
So that's an excellent question. Thanks, Linda, for asking that. So the neuroendocrine tumors that are removed by chance that are really small, oftentimes, so watch and wait can be really stressful. There's something that is actually termed scanxiety, where patients get anxiety right before a scan because they get the scan and then it's that waiting for your doctor's visit,
right,
waiting to talk about the scan. It's very anxiety provoking. Now think about that as people who are doing the watch and wait, where they are anxious all the time because they are constantly waiting for their next scan. Then they get to their scan and they're anxious to get the result and they're anxious to see the doctor. And then they get a couple of days of relief, but then it starts all over again until they wait for their next visit. So the watch and wait period can be really difficult, especially initially when you're getting used to kind of that mental fortitude you need to have to experience it. So many patients, again, it depends on the grade of the tumor, it depends on the type of tumor, it depends on the location, but oftentimes the initial scanning plan can be anywhere from 3 months to every 6 months to once a year, depending on the tumor itself, depending on the type of tumor that it was and what the risk is of the tumor coming back. So that's something that's really important to talk about with your doctor. Different types of tumors and different locations and different levels of aggressiveness of the type of tumor will really lend itself to your physician deciding how often you should be rescanned. And then the scan that you get in follow-up often depends on the scan you had at the time of diagnosis and also depends on what is available at the facility you're at. So for some people, it's a CT scan to follow up. For some people, it might be a dotatate scan or a gallium scan. Again, that depends on what scan you had done initially. We don't use those scans that often for surveillance. Typically, it's more likely to be a CT scan that's used for surveillance, but there are very rare situations where a patient may benefit from more specialized testing in the surveillance realm. But really, that's not done other than in specific situations. So I would say what I like to do for my patients when we're in that watch and wait period is I'll create kind of a form that I tell them to put up on their fridge, and it'll say exactly, for the first year, this is how often we're getting scans, and this is the type of scans. For the second year, this is how often. And that's really helpful for me, because then I put it in my notes so I remember the next time I see you what your plan is. And it's helpful for patients because at least then they have it, in their hand. They can take it home with them and they can say, okay, so Dr. Jane told me I don't need another scan until this point, so I can breathe a sigh of relief at least until then. But if I develop symptoms in the meantime, I know I can always call her in her office and find out if we need to do something sooner.
Absolutely. Well, thank you so much. I hope that helps. And thank you, Dr. Jane, for your time. I think that is our hour today, folks. So we appreciate you joining us and today. And as always, we hope that this program helped. And if you do have any follow-up questions, reach out to ccf@carcinoid.org, or you can message them here on the Facebook page. And one last time, this video will live here on the Facebook page continuously. You just go to videos tab and you can see that. As well as starting Monday, this video will be available on YouTube because a lot of people don't have Facebook. I just want to take a moment before we get off and say, I don't want to end on a somber note, but we lost a very special zebra this week who was a part of our 2018 series that we did, Stacy Chevrier, who is a dear, dear friend of mine, and I know a lot of yours at home. So I just want to bring that up and say that we love you, Stacy, and I want us all to share that love and continue to fight the fight that we're fighting, because we're fighting for people like Stacy, and she was an amazing human. So I just wanted to send some love to her. Thanks again to our presenting sponsor, Lexicon Pharmaceuticals. We couldn't do this without your support. And thank you, of course, to today's guest, Dr. Shikha Jain, which I had a blast with. And we've already got a date 10 years from now on the calendar to do this again. Hopefully sooner than that, we'll see each other again. But thank you again. It's also good to see your face. We appreciate everything you've done today.
Thanks so much for having me. This was a lot of fun. And definitely we'll do it again in 10 years, but again, sooner too.
Sounds good. Virtual high five. Boom. All right. Thanks, everybody. Listen, be healthy, be safe, and join us next time for Luncheon with the Experts. Take care, everybody.